I would like to present you the outcomes of our specialized unit we set up in Léogâne in Haiti for pregnant women. But you've seen the data before. Maybe just I think the cholera epidemic in Haiti is so out of proportions, big and unusual for the modern, for the 21st or 20th century. It behaves like the epidemics in the 19th century did, when the cholera was first spreading around the world. In Haiti, this is now the attack rates throughout the country from the national data, not just MSF. And within weeks and months, the whole country was affected, and the attack rates today, 8 months after the beginning, are reaching 3.6% at the national level. As the epidemic started really explosively in many sites at the same time, in the country that never had cholera epidemics before, so no one was used to it, people didn't know what to do. The treatment centers were overcrowded, there were hundreds of patients arriving per day. This photo was taken in Cap Haïtien, in our cholera treatment center, that was improvised in the gymnasium, in a sport hall in the city. Coming back to pregnant women, you can imagine that in Haiti, the prevalence of, there would be around 4% of pregnant women in the population, so they were among these patients there as well. The cholera in pregnancy has been previously associated with a high risk of abortion, and particularly with stillbirth. In MSF, we don't have much data really on that, but from previous big epidemics like in Zimbabwe, there were anecdotal accounts of our staff experts coming back and speaking about every delivery that happened in the cholera unit was a dead baby. And there was a web update in the early stages of the epidemic, an MSF midwife that was working in the MSF maternity hospital in Port-au-Prince reported at the beginning that in their isolation unit in this maternity, out of 70 deliveries, 14 were stillbirths, so it means like 80% of what he's seen were dead babies in that isolation unit. The literature on the topic is really limited. That's our literature review on the topic. Among the pregnant women, they've been reporting between 12 to 55% of fetal deaths. Now, it's very difficult to compare this data, and because some of them were published before there was oral rehydration salts used and so on. But it definitely shows a high proportion of fetal death. In Léogâne, after the earthquake, MSF established a 150-bed hospital covering all. It's a second-level hospital that has quite a big proportion of it is dedicated to maternal health. As the cholera epidemic started, we set up a big cholera treatment center in the outskirts of the town, and inside the isolation unit, inside the hospital compound, was used for high-risk patients, in particular pregnant women. We were hoping that with the closer follow-up of the pregnant women, we might somehow reduce the fetal loss. That's the unit, the inside of the unit. There was delivery unit inside the pregnancy ward, and then there was easy access to the surgical treatment and to neonatal intensive care unit. In the obstetric unit, in the cholera unit, we used the WHO protocol, but we were more aggressive with fluid replacement, because the logic behind was that the fetal death is directly linked to the even very short periods of reduced flow through the placenta. So all the women were given IV line, rehydrated with ringer lactate and ORS. We were monitoring very closely the hydration state of the women. They all received antibiotic treatment. We were systematically adding glucose at the beginning into IV fluids, and then continued with that if the women were not able to take an ORS, oral rehydration salts. And throughout their stay in the isolation unit, we monitored fetal status. We collected demographic and clinical data, both regarding the pregnancy and cholera evolution and the outcomes. The data was entered in Excel and later on analyzed by SPS. We didn't ask for ethical approval as we are looking retrospectively into analysis of routinely collected data. Patients' characteristic between the mid-December last year and end of February, there were 102 pregnant women hospitalized in the unit with median age of 26 years. Majority of women were in second and third trimester. The delay between the onset of the symptoms and by the time they reached the unit was 1 day. And the majority, when they were admitted, they were either mildly or moderately dehydrated. When it comes to the results, we had no case fatality. The case fatality rate among the women was 0, so no maternal deaths. Close to 80% left the unit with their pregnancy preserved. We had 7 deliveries of live babies in the unit. Of those, 3 were admitted to intensive care unit and 1 died 5 days later, so 1 neonatal death. There were 14 fetal deaths during this time, 7 abortions and 7 stillbirths. Of those fetal deaths, 7 actually occurred before although the delivery or expulsion of the fetus occurred in the unit, the fetus was already dead at the arrival. And then when we were very briefly looking at different risk factors, the risk of fetal death was higher in the second or third trimester. So between 14 and 60% of women in second or third trimester lost their fetus. And the risk of fetal death was strongly associated with the severity of rehydration. So 45, almost half of the women that arrived at the Plan C at the unit have lost their baby. So again, that's not a very scientific data. It's just a description of results from our unit. There is no control group, so there is no way for us to judge whether there is any positive impact of having a specialized unit or adapting the treatment protocol. But we were, nevertheless, compared to the literature available, we were able to describe quite a big cohort of pregnant women with relatively good results. We do think that pregnant women are definitely at particular risk, particularly their unborn baby, and should be treated as a high-risk group, as other high-risk groups like elderly children and so on. Clearly, the severe dehydration is associated with high risk of fetal death. So we do believe that somehow the very cautious, rigorous rehydration is important to prevent severe dehydration and to prevent transitory hypoxia in the placenta. And to be able to follow up the pregnant women closely, both from their dehydration and pregnancy status, we do think it's important to have specialized or separate places inside cholera treatment centers to address their particular needs. Many thanks. Thank you.